Good afternoon, everybody. Can you hear me is the first thing. Maybe Dorcas, if you could respond to let me know if you can hear me.
Yes, we can. I can.
Okay. So this is Barry Sieber, CRC with the DBHDS in the Office of Provider Network Support. In the room here, and just tons of people. We've got Nidra Ames, Beth Plink-Abatement, and Eric Williams, and me. So everybody else is online at this point in time. So welcome, glad you're here. We're not necessarily going to do introductions because there's quite a few people that have joined this time, which is fantastic. But we're going to start out with a colleague of ours, Rebecca Laubach, who's going to do a presentation related to the DSP competencies. Rebecca, are you ready to go?
I certainly am. Thanks, Barry.
Great. Thank you for
As
doing
Barry
this.
said, yep, I'm going to share my screen. As Barry said, I'm Rebecca Laubach. I'm a quality management coordinator at DBHDS in the Office of Clinical Quality Management, and I'm an advisory member to the Key Performance Area Work Groups that's also been looking at DSP competency. It's one of our PMIs, and I've been involved in part of that work through that work group. And I am here to provide an overview and then do a little bit of an exercise to introduce the exercise, and then we'll go from there. And so in an overview, both DBHDS, the PIRW, and SIRW, which is the State Issues Resolution or Statewide Issues Resolution Work Group, all of us have been looking at DSP competency and the overall staffing shortages for several years. On January 9th of this year, I met with the PIRW Education and Training Subcommittee to talk about a root cause analysis. From that meeting and their work, a specific root cause analysis document was created using the 5 Whys tool, and that document was submitted with the 24th study materials for our with the independent reviewer in DOJ. And then today we're going to ask you folks to complete 2 fishbone diagrams related to DSP competency. And so from that 5 Whys, there were several reasons overarching as to the root cause. And so we want to break down that further to look at some different elements, hence the fishbone. One is going to look at organizational factors or causes, and the other will look at process factors or causes. And then from that work, then we're going to use that work to further inform some work that we've been doing as well. And we'll share that with you after this has been completed, because we don't want to inadvertently influence the work that we are going to ask you folks to do. And so I'm going to move on to the next slide, which is the organizational issues. And so I'm going to expand this a little bit, and hopefully it doesn't get too big for you all. And so what we want to do, yep, I have to take it back down a little bit. Sorry, guys. All right, so what we want to do, our overarching problem is that both DSPs and DSP supervisors aren't meeting requirements for training and competency. And when we look at the organizational structure, we've got policies and procedures, staffing, administrative burden, resources, training and tools, and environment that are all funneling into this organizational issue relative to this problem. And so we want to, I'm going to show you the process one, and then we're going to come back to the organizational one, and we'll just get people started a little bit so you get a sense of what we're looking for. And then that's all that we're going to do, because I know there's a lot of things that are going to be happening in this meeting, and Eric has graciously given me a few minutes to introduce this, provide an overview, and explain the work, and let you folks go from there. So the second fishbone is related to process, and again, we have the same exact problem, right? And this time, some of our the themes are the same, some are different. So we have regulations and protocols, again, staffing, competencies, resources, training and tools, and environment that are funneling into that problem. And so that gives you an overview of the categories and what we're looking for. And so when we come back to the organizational issues fishbone diagram, we're going to pick one of these and we're just going to get people to give us some causes that they think within that category could be a cause for why DSPs and DSP supervisors are not meeting requirements for training and competency. And so what will happen is I'm going to ask somebody to pick a topic area, and then you folks can begin to give me a couple of causes, and I'll be typing while you're talking. So would somebody like to pick one of these topic areas? And Eric and Barry, I don't know if it's easier for you to ask a chat. I can't see any of that, so I need somebody to tell me what area we're going to start with.
There is a question in the chat, I think from Monica. She's asking
Okay.
if we are picking the topic first.
Yes. So of the 6 topics that are in the blue background, environment, training and tools, resources, administrative burden, staffing, or policies and procedures, which one would you like to start with?
Can you, anybody hear Eric? He was just speaking. Did y'all hear him?
No.
Ah, okay. So that kind of explains. All right, hold on just a quick second. Eric's.
Yeah, I was gonna offer an example. In chat, we had staffing and policies and procedures listed as 2 topic areas. And Rebecca, I think you're wanting us to drill down and give you specific examples under those areas. So
Right.
one of the things we learned through the systems issues resolution work group meeting recently is that under administrative burden, an example could be if if a provider is supporting an individual with tier 4 support needs who has autism, complex medical support needs, and behavioral support needs, that provider is looking at 28 pages of competencies for each staff person within 6 months of hire. So that's a lot of volume in terms of competencies and a lot of paperwork and a lot of management in terms of getting that done. So just the volume itself is challenging. So that's an example, I think, under administrative burden that might work. And so we can go ahead from there. If others have examples, they can drop them in chat or just raise your hand to unmute.
So any other ideas? We've got the policy and procedure and staffing as 2 of the potential topics at this point.
Somebody said noble care.
Yeah,
She
shortage
said,
of shortage of staff. I can see that.
yes.
Unclear procedure. Okay, so Rebecca's typing that in.
Nancy's hand is up.
What was that last one?
Nancy Simmons, her hand is up.
Oh, okay.
Nancy, you can go ahead and unmute and raise your question. Okay. Now Tanya's raised her hand.
You can also put your answers in the chat if you cannot unmute. For some reason, some people cannot unmute.
Yeah, we can't unmute on this end either. So if you would put your question in chat, we can see that. Tricia, if you could hear me, can you try to unmute on your end at this point? No, apparently not. I'm not seeing anything. And there's a lot of comments in chat coming up though.
I guess just go to the chat. Like we go back to.
So Rebecca, do you have what you need to go ahead and start?
I do, and actually what I'll do is I'll look at what's in chat, and I do ask that as you folks begin to work more with this, that you stay away from putting in any solutions, right? Because it's real tempting for us we identify the problem, here's how we could fix it. And we don't want to move into that realm just yet. It's really making sure that we've got the best, clearest picture we can of what is going on, because there's going to be multiple things that can come out of this. And we want to make sure we've got as many of our root causes identified so that our work is more successful and more effective. And so I'll put in what you folks have been entering into the chat. And then whatever is left, then Eric will send out for completion, and then it'll come back to me and I'll move us along to the next step. So thank you all so much. And I'm going to stop sharing and put myself on mute.
She's going to keep working.
Right. Okay, so we'll go ahead and move on to to you. Yes, go ahead. Okay.
For some reason.
Eric's going to switch places with me because his mic's not working.
All right, so I'm gonna give an update on the Administrative Burden Subcommittee. So we did meet in between meetings. As you may know, a lot of our focus has been on the development of the new ISP, focusing on the build out. We're going to continue to talk as we move towards training and move towards launch. To give you an update on where we are right now, we have confirmed with the vendors. We've given the final specs to the vendors who do the data exchanges for CSBs. We are targeting August 1st. We've confirmed August 1st as the go live date for the ISP. We will initiate training as soon as we have access to the test system. We are meeting as a team internally. The provider network supports is meeting next week to talk about supplemental documents that need to be updated related to the changes in the ISP. I'm going to go over a couple of those today. Just to give you some insight about what the group will be working on and looking at. Training will probably begin in, we're hoping early June is our hope, so that we can train in June and July to prepare for the August date. The two documents that I'm going to pull up first, let me see if I can share my screen. All right. All right, so two of the documents that the group will be looking at the next meeting are a draft of the person-centered review and the Part 5 template for providers. So if you're a provider, you're aware there are two options to enter information into WAMs. One is through direct entry complete use, and one is through modified use. So modified use is the option that we produced this instructional template for. A provider would only enter required fields in the system, and then they would be able to upload a template or their own formatted Part 5 in its complete version instead of actually using WAMs to the full extent. So I'll start with Part 5 and then I'll talk about the review. So the Part 5 itself looks very similar to what you've seen in the past. Hang on. If you need that bigger, you can go down to my name and hit the plus sign on the lower left-hand side of the screen, and that should zoom it in for you if you need to see this a little bit better. All right, so we have instructions as we have previously. I'll highlight a couple of important instructions that have been added. So one of the things that added is, we're going to continue to have outcomes in the plan. So those outcomes are going to focus, if you've seen the video, we're focusing on what's important to the person and where they want to go in life. So those important two outcomes will still be part of the plan, and some of the activities that you as a provider support someone with under those outcomes might have instructions that come from the essential supports section in the plan. And this instruction says it's perfectly fine under those activities to point to the essential supports section for those instructions instead of duplicating them at two locations in the plan. And then the second instruction here is that says that where external protocols are part of the ISP, the essential support section can reference where these are located and accessible. So the same way you can point to the essential support section for activities instructions, you could also point to external protocols. Same thing for essential supports, you can point to external protocols. But the point is, if you don't put it in the space in the ISP, you have to say where it's located and accessible for the DSPs to be able to locate and find. And I'm going to scroll down and actually show you the format a little bit. So this is very similar to what you already are familiar with. We have the outcome, we have the life area, we have key steps, we have the activity, the measure, what to record, skill building, how often and by when. And then at the bottom, we have the instructions for staff, for DSPs. So that's the plan you know today. But what we've done here is we've modified it to include a secondary section, which is below the outcome section. And that secondary section is called essential supports. Now, for providers using WAMs completely, all of this would be done in the system. Once the ISP is completed, the part 1 through 4, so actually it's the Part 3 is where all of these risks will be identified and routine supports will be identified. They will push forward in WAMs the way outcomes do. And providers who are doing modified use, at a minimum, have to include the frequency and include that in the WAM system. They won't have to include how to support. They can do that in the Part 5 template or in the provider-generated Part 5. But if you're using WAMs completely, you would be sure to complete both of these fields in the system. The identified risks will pre-populate from Part 3. Potential risks will pre-populate from Part 3. Routine supports is where it diverges because under routine supports, providers have the option to select those routine supports that apply in their service and setting. So you'll notice we've changed the instruction here from populate from Part 3 to selected from Part 3. So a provider would select the routine support, they would enter the frequency, and then they would put the instructions for DSPs on how to support the person. That is a little bit different. So we added a confirmation here to the Part 5, and this may change. Again, this is a very early draft. This is not done yet, so please bear that in mind. The subcommittee will look at it. We may make additional updates and edits to it, but we're trying to move forward with updating what we can in anticipation of the change. So this statement says, plan writer confirms careful consideration of all routine supports and has selected all that apply in this service and setting. Yes and no. So there's a confirmation from the provider that under routine supports, we did look at all of them. We did pick the ones that apply in our service and setting, and we're confirming that. So right now, those are the primary changes to the Part 5 template, which really generally happen under the secondary section for essential supports. So you notice there's no support activities, there's no key steps, there's none of that. It's basically the begin date and the end date will come over from the Part 3 with the dates of the annual ISP year. And then providers will have the option to end things early and to add things that are identified during the year. So the updates to the essential supports will happen in Part 5 revisions. Those will be submitted to the support coordinator per usual when plans change, but it will not modify the listing that's in the shared plan in WAMS. The way outcomes change when revisions are approved will not happen with essential supports. That will be a static list. It'll just be in there. This was what was true at the annual. Any changes are identified through the Part 5 revisions. So any questions about this format or any thoughts on, or just immediate thoughts on anything that we need to do to think about next week as we talk about how to make this better? If you have any thoughts, you can drop it in chat. If it makes sense, you can say, yeah, it makes sense. If you think it doesn't make sense, you can do that as well. So let me see if I can look at Barry's screen here for a second. Okay, we have a question about, will this be recorded again to watch later? So are we recording this? Yes, we are recording it. Yes. Is the new section to be included in the ISP for documentation as well? It's the new section to be included. So we are also looking at documentation guidance and ways to document essential supports related. We actually have been talking, I was talking with Dorcas today about progress notes and how to possibly make recommendations for a progress note that will document the essential supports, be available to document ongoing skill building and different types of supports, but also meet requirements under the HCBS settings regulations. And that is actually an activity that one of the members of the subcommittee, of our subcommittee administrative burden, has taken on to draft for us, is some guidance around note writing for HCBS. So that's the first project we've actually taken on, and we'll be working on that as well. All right. So, and then I have a question. Did you mention what this replaces or eliminates? So that's from Jennifer. So what this replaces or eliminates is the need to be as complicated with the documentation of risks and the documentation of routine supports. So you don't have all of those layers of requirements in terms of documentation. So the other thing here is that it basically makes it easier for providers. So will we be able to modify, thank you, Jeff. Will we be able to modify as a new plan year comes about per individual, or is this once implemented in the system, we will need to have the change on all of our Part 5s? So what happens with the system is it rolls over on the same date for everyone. So August 1st will be the launch date. So any Part 5s you develop after August 1st would need to meet the new standards, because that's going to be the template that's used in the system. So, all right. Let me see. Are you completing this routine supports if you are in modified version, or is it upload applying to this? So basically the Part 5 template is developed to replicate what's in the system. So the routine supports, it's going to be the same content, and either you fill it out in the template that we provide if you're doing modified use, or you reflect the same content in your provider developed Part 5, or you fill it out directly in the WAM system. So I don't know if that answers your question, but hopefully it does. Okay. So the new template, because it's still in draft form, we haven't made it available yet. We're going to continue to work on that. It may be different the next time you see it. This is just sort of an initial run of trying to get something that will work for people. Okay. Any other questions or thoughts about the Part 5? If not, we'll move on to the person-centered review. Okay. All right. Give me 1 second. Will this be included in the training plan with ISP 4.0? Yes, it will. So we'll have to have this done prior to the launch of the new ISP and have providers introduced to it and understand the new elements and how to meet the requirements. So yes, we will do that. Okay, give me 1 second. Either way, okay. All right, so this is the draft person-centered review. Please bear in mind, again, this is draft, it's not final. We will, as a subcommittee, continue to talk about it internally at the department. We'll talk about it. So don't think this is set in stone. So we have what we have currently under outcomes. So we have the start date and the end date of the outcome. And then we have our status, which is achieved, on track, limited or no progress, and then the status description. So basically comments related to the status that the provider selected above. We have the same area where is a plan change needed, yes or no. If it is, you describe what that change is. Okay. Now, all of that's the same, but if we go down, you'll notice there's a new section in the PCR called Essential Supports. We have the start date and end date. And then we have this new option here. Actually, I'm not able to do it in this version, but you see where it says select risk, there's a drop-down menu that has all of the risks listed. So providers will be able to go in who are using this template and just hit the drop down, choose dehydration, and it'll populate dehydration. Then they can go achieved, on track, limited or no progress, and then describe the needs around that. And then if there is a change with dehydration, they'd be able to mark, yes, a plan change is needed, and they can describe that change. So this is going to be true for both identified risks and potential risks. So there'll be a way to actually drop down and select each risk. Now we're going to go down to the routine supports, which looks very different. And I'll be honest, this was a bit of a challenge to kind of figure out because there are so many routine supports. So I'm thinking that what I'm thinking is that we can treat them as a group. And so it's sort of a snapshot of routine supports, right? So you would have a start date and end date for a person's all of a person's routine supports until one or more of them changes. You would select the current routine supports. So at the time of the annual, it will be the one selected for that first quarter following the annual. You would check all that apply. You would put achieved, on track, limited or no progress, and then you would comment about why there was limited or no progress. So you might say, continuing to struggle with laundry, not interested in choosing not to participate in laundry, continuing to have trouble with that one. Or they might say achieved and say, there's no additional need for medication use. Medications have been stopped. We can take that out of the plan, and then you would describe that change over here in the last column. All right, and then the next quarterly, it may look different because of the changes from the previous quarter. These changes would also be part of modifying the Part 5 plan for supports to reflect those changes. All right, we have a question from Andy. Also, will there be consistency regarding when a risk can be addressed in safety and when in routine supports? CSBs are inconsistent with expectations. So if a risk is one of the ones that are part of the universal list, they will be, what the risks are. So when you say,
you know, if it's a universal risk, it's going to be addressed under risks. Those are the only ones from that list that are going to be addressed under risk. The only way other types of risks or support needs or chronic health conditions are going to be addressed are going to be under routine supports under other. So you see down here, other routine, other medical, and other behavioral. So things you might identify through the supports intensity scale are going to be listed here, different kinds of things that come up. And so, you know, it's basically, if it's part of the universal list, it's always going to be up here. And if it's part of routine supports other, it's going to be down here. So it's going to be in one place or the other. Andy, I don't know if that answers your question. Okay. Any other thoughts, concerns, or questions about the person-centered review? Okay. From Claudette, can you tell me what this would look like in WAM's input in the part 5? Who will be Who will be responsible for the new revision in each section? So for WAM's input in the part 5, it's going to be the provider's responsibility as part, and the person-centered review is not in the person-centered review is, of course, not in WAMs. It's just the Part 5 template that we talked about a moment ago. But the provider will be responsible for logging into the WAM system, for either doing complete use and filling out all the fields directly in WAMs, or they will do the modified use. They'll enter the minimal elements required, and then they will upload their full Part 5. So it's really the provider's role for adopting things that come over or are pushed from the Part 3 and waiting for the provider when they log in. Or for routine supports, it's on the provider to make a selection from those routine supports that are appropriate for that service and setting. So it's really going to be the provider. Okay, so I have a question from Andy. Some risks are identified that are from the list, but not really for the person. For example, autism equals seizure risk, not true for everyone. Okay, so if someone has a seizure disorder, seizures are on the list. So that would be addressed as a seizure risk on the list of risks under potential identified risk section. That wouldn't be under other because that is on the universal list. So I don't know if that helps. But it would be tagged as a seizure risk. Okay, and then Erica, which providers? So is there a certain service you are providing, Erica? So Erica, if you can tell me which provider you're worried about, it would be all providers currently required to do their Part 5s and WAMs. Oh, yes, DSP. Hold on. Deanna says, I question the need to have a start date and end date for the PCR under routine supports within the PCR. You are reviewing progress over the entire quarter. Oh, that's a good point, Deanna. We can look at that. I think that we probably will have to talk to Medicaid about it to figure out whether or not they're going to require us to have a start date and end date. Typically, everything that's in the plan has that start date and end date. I know risks need to have the start date and end date. So we'll take that back. Thank you for the comment. Andy says people get tagged as seizure risk if they have autism, even if they have never had a seizure. Right. So if there is, when you have a potential risk, so maybe somebody is scoring as being at a potential risk for seizures, but we don't know, they've never had one, that sort of thing. Then the person is offered a referral to a healthcare professional in the Part 4. If the person declines that referral, then the team can write in the comment note how needs will be met outside of sending that person to the doctor or doing it that way. So if there is, it may be as simple as discuss with the doctor annually to confirm no elevated risk. And that's something that the team could decide on as a suitable resolution for that situation. Okay, great. All right, any other thoughts, questions, concerns, ideas? You know, and if you do have something that comes to mind later and you want to make sure we consider it, send your comments to your provider team CRC. We are going to be together early next week, but we will continue to be meeting over this over the next couple of months. So just, you know, send your comments along and we'll take a look at them. Does anyone from the Administrative Burden Subcommittee want to unmute and share anything related to the work that we've been doing? Okay. All right. If not, then we'll go ahead and hand it off to the next group. I'll hand it back to Barry and we'll let him take over.
All right, back. So we'll go ahead and talk about, it shifted a little bit in the agenda. Dorcas asked to postpone for a bit. So we'll start with the system functioning group. And I'm just going to kind of go over the things they're working on and looking at. The first several recommendations, it ties back directly to DBHDS because it's looking at funding for that to change elements in the systems.
Barry,
Starting
are
with
you sharing?
no. Would you
Okay.
like me to share?
No, just wanted to be sure.
What do you see?
What are you seeing, Dorcas?
Nothing.
Okay. I'm just going to go over what's the committee's working on at this point. I can share, and I have to hunt it down, but I'm going to just go ahead and cover it because time is going by fairly quick. So the CRIS system, the discussions that we had there was about the timeout that occurs in the CRIS system and the fact that you can be entering the information, it times out, and then the data just gets lost and you kind of have to start over. So the push is to try to update that system so that it doesn't time out as quickly, nor does it lose the data if it does time out, that you can come back and you're not have to spend extra time do that. Again, that's going to depend on DBHDS funding to change that system. The other one was the fact that submitting it and you have to do it twice, one to Office of Licensing, one to the Office of Human Rights. And if in the midst of updating that system, could we set it up such that once you submit it, it just automatically goes to both offices, saving time? In additional training, set up online training so that they're able to review and learn how to use the system. I don't use the system, so but it sounds like it can be fairly complicated. And developing job aids, so the committee will be working on that as far as those recommendations of what would be the topics to be addressed in that. Also, again, a lot of this has to do with submission of documents. So having a online portal for uploading folders for Office Licensing, Office Human Rights, and regulatory reviews. So simplifying it so providers are not needing to go to multiple portals to upload information. Again, all these are tied back to DBHDS funding approvals. One of the heavy lifts is doing a crosswalk between the HCBS regulations, licensing regulations, and human rights regulations. So working on that piece and getting that together. And then there was a recommendation here about the risk awareness tool and being available for provider 4 weeks ahead of time. But now with the RAT to ISP process, I think that will change, and we'll look at that recommendation and possibly remove it or change it in some format. That's what the group's working on. Anybody from the system functioning team that would like to pop in and say anything? I think Jennifer added in here, what's the status of the CRIS RFP? Eric? Okay. I don't know if you heard that, but Eric said, we don't know, but we will check with Dave Nair on that. Any other questions? None? Nothing in chat? Excellent. All right, so the other committee that I've ended up kind of, I haven't actually worked too much with them, but is come my way is for education and training, but they are working on primarily looking at the competencies and how we can adjust those competencies to make them more useful. I know Rachel Ashworth, I can't see if you're here without scrolling through. Are you here, Rachel?
I am.
Okay. I know you and I had been sharing emails. Did you want to share a little bit about what you're thinking about?
Sure.
Great.
So I did review the three of the four competencies. I went over the DSP, the health and the behavior competency, looked across them for things that were duplicated or, had similar language, either within the same competency or across the others. So for example, like relaying and translating health information, that's found in multiple places on the health competency, or either it has very similar, language within those things. Being a role model is addressed in the DSP competency as well as the health competency. So there were things like that. So, I did send you the things that I had identified, and also we need to work on the autism competency. But, we're going to continue to talk about these things as a committee and look at what language needs to be changed to ensure it's person-centered, and then address those duplications as well.
Yeah, that's great. Thank you, Rachel.
You're welcome.
There was also one, and this came up quite frequently when the competencies came out, about having the advanced competencies, was to have set curriculum to be developed for those. So there's discussion going on about that piece within the committee. Okay, yeah, and this committee will work through that fishbone exercise. So that pretty much covers it for that group. It's a heavy lift with all the competencies with that, although all the groups are doing great work. Any questions? Okay. So that brings up Dorcas.
Hi, I am going to share where we are with complex health needs. We met in March, and we talked about the team discussed the action items that we have developed. I am going to share my screen. So we talked about the action items that we have developed. We discussed the background of each recommendation, and we talked about how to approach each action or each recommendation. So the first recommendation, to develop training to describe the role of DSPs, providers, and support coordinators in implementing behavior support plans, that have been assigned to Monica Chandler, Christy, and Andy. Do you have an update, Monica? So I don't know if Monica, Christy, and Andy, Andy is here, but this is what we have assigned to them. The targeted date is October 1st. The second recommendation, and the areas are assigned or designated by the teams, and it was based on their area of expertise and also area of interest. So each member assigned themselves or attached themselves to the recommendations developed. The second recommendation, to partner with DMAS to develop training or guidance document for behavior consultants on a clear definition of allowable activities. I know Monica was developing a draft to send to DBHDS. So when we meet again, we are going to talk about where each team member is. Our next recommendation for the Office of Integrated Health to promote an increase provision of one-to-one consultation on complex health needs to providers. Kelly is not here with us today, but she has developed a beautiful email and has sent it to our recommendation to the Office of Integrated Health. We looked at their website. We realized that it's difficult for providers to access RN consultants. So that was one of our recommendations to make it more available and their site user-friendly for the providers to able to access the information and the resources they have on site, and also to know who to contact when they go to OIH site. And our next recommendation to provide information on the documentation needed as part of treatment plan when developing, when supporting people with complex needs who require frequent emergency medical visit to reduce concern. This recommendation is assigned to Monica, Kelly, and Brittany. They are still working on it, so we don't have any updates yet, and we have Monica who will edit the draft. There is another one to develop means for providers to share their learning and experience around supporting complex needs with each other. And that is also being worked, it's assigned to Monica and Brittany, and they are also working on it. So we don't have updates regarding this one. We have two other recommendations that we said we were going to refer to Office of Integrated Health, and we did that. Kelly has sent a recommendation to Office of Integrated Health. We reach out to them, and we are here to receive any feedback, whether they are going to consider any of the recommendations. The three recommendations we refer to them. And there is last recommendation to DMAS that we haven't worked on. So that is where we are with our projects. Any questions? And subcommittee members, if you have anything to add or anything to share, please feel free to do so. Okay, so Monica said they don't have any updates yet, so. So I think I would hand over to Sophia.
No, we've got a comment in chat. So let me cover that from Chip. I'm not a trainer, so sharing those thoughts from a 30K viewpoint based on chats with SSVA team. With the staffing shortages, limited workforce we have, it would be nice to significantly streamline the base level competencies needed to get on shift right away. Many DSPs don't make it past their first month or two, so it makes it no sense to invest tons of money and time into training them to be thoroughly competent early in their career. Also, it is hard to learn the skills in the classroom without real world experience. Then after the staff has been with us for 90 to 108 days, then we can increase their level of competency by investing the money and time into their training. This is a big driver of admin burden and the hassle of onboarding DSPs. Also, DSP generally prefer on-shift training over classroom training, so this strategy may help with the retention. So, okay. Thank you for that information and your thoughts there, Chip. That's helpful. Yeah, so okay, up next will be Sophia May Smith to talk about the System Transformation Group and their work.
Good afternoon again. This is Sophia May Smith, and I am working with several others on the System Transformation Subcommittee. And we have 4 recommendations that we've brought before this group, and I'd like to give you an update on those. Excuse me. The first one is that the PIRW recommends that DBHDS work with DMAS to ensure that waiver rates are adjusted annually to align with the cost of living increases. We've done quite a bit of background work on this, and we've come to the conclusion that this recommendation is important, but it should be addressed at the policy level for the state agencies. We also thought we could develop a policy for this recommendation and share it with the state agencies referring to DBHDS and DMAS, and that it be considered complete. We also want to support those private and provider coalitions that are continuing to work on this issue at the legislative level. So this committee, we have a draft of a policy that Tanya has worked on for us, but as a group, we have not yet reviewed it, so I'm not going to share that today. But I wanted to let you know that we are considering this part of our work complete once we look at that recommendation of the policy and move it forward. The next recommendation that we have is that the PIRW recommends that DBHDS identify and implement strategies to reduce the administrative burdens on support coordinators and providers in an effort to increase job satisfaction, reduce turnover, and increase the quality of services provided to people with DD and those who support them. This particular recommendation, we have something that I will share after I go through the other 2. We actually had some of our members to send in lists of some of those burdens as they have experienced it or are aware of, and action steps that may help to alleviate or begin to think about how to alleviate these burdens. So I will share that list when I'm done. And again, several of our members sent in information. I compiled it and took out whatever redundancy there were. Tanya again put that together in another format. She did complete it, but because the group has not yet reviewed it, I won't share that, but I will share the draft that I've put together for you. It's not attractive looking, but it's got the information that we need. The next piece is the PIRW recommends that the DBHDS assess the impact of providers of implementing the requirement of the settlement agreement in context of other regulatory requirements to identify methods to increase efficiency and contain cost. One of the areas that we seem to have focused on for this is the employment support organization. And Adair is working on bringing us more information. We did get feedback from Heather that they are working on looking at this particular issue, but it has not yet happened. So we're going to continue to monitor that. We also want to look at specific regulations that is directly related to the settlement agreement and the DOJ and narrow down our focus. And another piece that has been brought to light by our members is that the HCBS audit specific to group day support, it is just not feasible to have autonomy and such at the day program and maintain 1-to-7 ratio because this does not meet the need of HCBS. But this particular program type is a choice by the individuals. So we are still working through that so that we can bring something a little bit more tangible and focused. But this is where we are with issues around the settlement agreement. And the last piece is that the PIRW recommends that DBHDS revise recommendations to enable group home providers to maintain a separate designated bedroom under their residential license for the sole purpose of providing respite services while retaining the lower census for group home billing. And this recommendation, we've gone back and forth. We've looked at the DOJ settlement language around the group homes with 4-bed or less, what that mandate says. We've talked about it. We have a respite provider on our committee who has shared some of their personal experiences. And what we're doing now is just trying to see with the new guidance that came out for the LRI, how does this impact those providers that are doing respite in a type of brick and mortar where the individuals come to them so that the primary caregivers can have a break. So we are still trying to figure that out. We've talked about it. We've looked at what was shared from Jailhouse as a model, and we think that would be a good model to have for respite going forward. But it's still a work that we're continuing to work on. So I'll switch gear now and share with you what we've put together. Let's see, is it sharing? Dorcas, can you see a new document? Okay. Yes, so this is where we landed with the contributions from the different members of our group. And this is, again, recommendation number 2. And I categorized them according to the feedback that I received. And the first one, we're talking about administrative burdens for support coordinators as well as providers. And this recommendation came from a non-licensed provider who is on our team. And there's concern that when a client transitioned from the CCC plus waiver to the DD waiver, there's supposed to be a continuity of care for personal care authorization for 30 days so that an ISP can happen. An ISP is developed, the service facilitator can conduct an initial plan of care to do a visit, and all documentation can be submitted and approved for their start of care date. And I broke up their issues and recommendations as such. So number 1A said support coordinators don't always have all the paperwork completed, and they gave examples of those. And a possible resolution for that is that they do not allow the start date for the DD waiver until all documentation is completed by the SC and uploaded into WAMS. The next issue they brought forth is that the care coordinator with the MCO and the support coordinators with DBHDS do not communicate with one another throughout the transition, which results in either a gap in the coverage or an overlap in authorization. They're suggesting that care coordination must be present at the ISP meeting in order for both parties to be clear on the start and end date for each waiver. Also giving the service facilitator visibility in VAMIS to see the start and end date for each waiver would be helpful. And lastly, another option would be to program VAMIS in such a way that the gap in coverage or overlap in waiver start and end date is not allowed to be entered no matter the authorizing body. If you have questions as I'm going through this, please do share. And if you have other issues that we need to take a look at, you can place those in chat. So moving along to the second piece for the non-licensed provider is that the ISPs are either new to service individuals or reauthorization for existing services are supposed to be completed and sent to the provider at least 30 days before the start date. The issue appears to be that this is not happening consistently, and it seems that support coordinators are not being held accountable for it. In fact, it happens more often that the service facilitator does not receive a new ISP until just a few days before authorizing is due. And to be clear, this is happening all throughout the state, not just in one region or another. They're suggesting that a resolution might be someone at DBHDS needs to access to the dashboard that clearly shows when the ISP have not been completed timely and needs to hold the CSB accountable to getting them done on time. And again, we're looking at a draft of where we are going to take our discussion and how we're going to flush these issues and resolutions out. They also share that almost every request we submit is penned for some reason or the other. And the issues may be extreme inconsistency between reviewers, between CSBs, between regions on what is pended and what is not. We spend countless hours attending to pens. We do not get paid for this administrative time spent on going back and forth on pens. We only get paid for visits. So they're proposing a resolution might be, rather than pen being free form, text box and WAMs, perhaps it would make sense to standardize the reason based on the regulation and manual and give support coordinators option rather than letting them type a narrative. Provide them with training on when each option is appropriate. And then again, someone at DBHDS should see the pen's reasons on the dashboard and should regular monitor each one to ensure they're being used properly. They also feel that there's an issue with the QMR audits, which are too long and too numerous. And they're suggesting that we required to meet with reviewers in person. We do not have offices all over the state. And can't we meet via Zoom? Or another issue is that we are presented with our findings, we create our corrective action plan. This take ages to get approved with a lot of administrative back and forth. So a resolution might be for part of the review to include training for providers on what acceptable cap looks like so that we can try to get it right the first time. And reviewers need to be consistent about how they review our caps. More about the cap is that once our cap is approved, in another 6 months, the reviewer come back and essentially does another review. Since repeat of the first process, we must create a new cap if there are any findings and then come back into another 6 months to do it again. They're proposing that if the cap is approved the first time, then why is the second or third review necessary? This seems to be a redundancy that can be removed. So next, we're looking at licensed providers' administrative burden. That broke out in a way that says we do not have the resources to hire new people when new administrative burdens are put on us. The issue appears to be that the number of reviews we are subject to annually or semi-annually, such as the HCBS desk audit, QSR, licensure reviews, including review of quality improvement plan, risk assessment, and policy concerning both license renewal and triennial for us. Since the pandemic, most of these reviews are done remotely, so it is no longer the responsibility of the licensing specialist or other reviewer to come in and review our documents. We must gather and provide all of that for them through Connect system or through other systems which we must learn to navigate. So a possible resolution is that many of these reviews are asking for the same or overlapping information. Why can they not be combined? Another piece of this for the licensed provider is that the number of electronic systems that providers are expected to know how to navigate, such as Connect, MES, WAMS, CRIS, which is less often, Learning Center for the Commonwealth of Virginia. These are all just systems that we use to interact with DBHDS or DMAS. These do not include any of the other systems we use on a state or federal levels to report employment-related information to those entities. For smaller providers, many of us have to have multiple people that know how to use these systems as well as doing other duties. So a possible resolution is they would ask that there is a reason why we could not combine some of these systems. Taken out of context, each of these systems might not seem difficult to navigate, but adding them all together to create a burden that many smaller providers cannot shoulder. Moving along, it says we continue to get more and more guidance for newer procedures, policies, and standards. Sometimes the sheer amount of communication from DBHDS and DMAS makes it difficult to keep up with everything. They're suggesting that they do not know how to solve this or other than asking different departments to potentially consolidate their messaging so the volume of emails isn't so overwhelming at times, or asking the provider to sign up for more specific email lists so that we do not have to receive emails that don't pertain to us. And again, they would like to receive information on new guidance in a timely manner. And a possible solution is not to mix in new guidance with a bunch of other information that does not pertain to us. It is much harder to identify important information. And then we see that the general expectation that providers and support coordinators should do more with less. For example, more responsibilities added without more compensation. So an issue appears to be the model of in-home services such that many providers are not the primary caregiver and may not even assist with medical or dental appointments. Yet, we are receiving citation if we do not have a current physical or dental appointments on file. So people in in-home care choose not to get physical every year, or they choose not to have dental cleaning every 6 months. We do not believe this should be disqualifying them from services or be the responsibility of the provider to ensure what is happening. So a resolution is that on one hand, the system is meant to honor individuals' choice, but do not allow for any wiggle room when the individual make different choices than what the state would like. And then we had a few pieces for support coordinators and provider administrator, and this is looking more at some of the things we identified around job retention. One moment, I want to give you the specific language. Job satisfaction, reducing turnover, increasing quality of service. And this contributor said that we need to increase job satisfaction. And some of the things they think we should consider is quarterly training on regulation, documentation, shadowing 30 days, reduce large caseload, supervisors should know their staff and have an open door policy, have discussion on frequent changes in regulation update, routing supervision and supports through accountability, consistent interpretation of the DD regulation among DMAS, DBHDS, offices, CSB providers, CRC, and providers should have education and prior experience working with the DD population. We should also consider getting a census from the providers and the SC regarding what makes their job satisfying. Some provider burdens can be relieved with simple internal process control. Often, as the provider, we are asked to provide documents that we previously provided to a different person with the same agency. And to reduce turnover, they would like to see pay rates according to the cost of living for cities and locality areas. Continuing education units offer incentive money for a portion of it or all of it. Ongoing training relative to the assigned job, in-depth training for SC prior to assigning caseload, smaller caseload, end the repetitiveness of paperwork, purchase a system that would pull in all documentation requirement from previous data entry, reduce inconsistency in required policy. Providers should give advanced training to qualify DSP for promotion within the field. For day services ratio 1:7. And then we have increase the quality of services provided to people with DD and those who support them. So offer ongoing training on the world of DD in Virginia for doctors, dentists, ER physicians, new professionals, families, regular citizens, etc. We need clear guidance to locate resources and access the support. Improvement needed by state agency to be more active than reactive to the needs of the population, providers, and SC. Make the provider roundtable webinar more interactive and regional. Disseminate changes in regulation frequently during a specific time to reinforce the information and allow others to see the memo. Have consistency from region to region in the DD waiver expectation. Purchase an IT system that can become the central database and repository and connect across all users, example, state auditors, providers, CSVs, VDSS, SS, and provide access according to the needs to know or to use. And lastly, we have the support coordinator administrative burden. There seems to be a high turnover of support coordinator, and the issue may be support coordinators listed in WAMs are not getting updated when someone leaves, and our request therefore falls into the black hole until we run up the ladder to get it moving. Possible solution is when an SC leave, would it be possible to programmatically update WAMs with a mass update that changes the SC name to their supervisor's name for authorizations to have visibility to someone and not fall into the black hole? I know that I've read quite a bit of information to you. As I said, this is a draft. We've been having this discussion since we began to convene, and you can see a lot of thought has gone into it. We're going to go through these, flush them out, and this is after I pulled out anything that appeared to be redundant. Are there any questions for us? This is recommendation number 2 that we are taking to task. Any member of the group there that would like to share, ask any questions? Have I missed anything that you want to talk about? Okay, hearing none. Anything in the chat, Bear?
There are questions in the chat. Some are
Okay.
comments. Chip said, one other problem to add to the list of the new overtime rule that will increase the base salary threshold for non-exempt workers. If this goes into effect, it should significantly impact mid and possibly upper level management in our field. Possible outcomes will be increased overtime expense, increased salary expense to bring up the wage of workers above the threshold, or the added administrative burden. Hold on, threshold, hold on, I guess I missed it. Of tracking hours of administration or administrators who fall behind, or sorry, below the new threshold. And there is another comment here, positive behavior support training for DSP is never close to home. Few companies to choose from and very expensive with annual retraining. Can this not be online? They have simulations online for ACLS. Now surely they can do positive behavior training. Jackie, thank you for your comments. The reason for developing this recommendation is that the team realized that when a plan is developed and staff are trained, the behavior consultant, when they go back to the service after a period of time, they realize that the plan is not being used, and sometimes the plan is not even nowhere to be found. And the same provider will also be looking for another behavior consultant for the same person. So the purpose of this training is not only for the DSPs, it's for the DSPs, the providers, and even the support coordinators as well, to describe what behavior consultation is, what it entails, expectation of all staff supporting a person receiving behavior consultation, and how to provide ongoing training to new staff. So that is what the team is going to draft. This is a good idea. I believe the team members working on this recommendation would look into the simulation online and then take that into consideration when developing a draft.
Thank you, Dorcas. And I see there are other comments. What I will do is take these other suggestions to the team and add those in. So I do appreciate the contribution and the feedback.
Thank you.
So we good? Okay. So, hold on just a second.
Sophia, do you want us to quickly read the comment, or you want us to, you are going to take it back, like you said?
Okay. All right. I think we got fixed here on this end. All right. So
Okay.
there were some comments about the pins. There were a few of those in there and some inconsistency. We will take that forward to the Office of Waiver Network Supports and have a discussion with them about that. We've lost several committee members for the PIRW just because of other work duties or people leaving positions. So we are looking to have some new members join us. So if you have anybody that's interested in joining the PIRW in any of the work groups at this point, or just join it in general, please send their name and contact information to myself, Barry Seaver, and to Eric. Copy Eric, please. And we'll take a look and consider that because we'd like to keep the numbers up in each of the committees and get different perspectives there. With that, we're done, unless you have other comments. Any comments from the group to end out? Thank you for everything today.
Thank you for all the input. We will look forward to seeing you next quarter, and subcommittees will be meeting in the interim and to continue working on the work plan. So thank you so much for joining us today.
Yes, we will be saving the recording.
We'll send it out.
And we will send it out, yes. So again, thank you. Appreciate your work here and your subcommittees and continued work. It's very helpful to us. Thank you.